We're going to have our panel discussion here. So if Dr. Silversides can join us on Zoom.
I'm on.
Excellent.
Hi, everybody.
Hi. Hi, Candice. How are you?
Great, thanks.
Thank you. Welcome. All right. So we're going to take some questions from the audience here, and also we'll take some questions from Zoom here as well. So you can come up to one of these microphones if you want to ask your question. And I can start with a question to Dr. Lorenzi. So really wonderful talk, Lauren. When and how should we refer these patients to see a neurodevelopmental specialist?
We have really tried to take a preventative model at Children's Hospital of Pittsburgh and beginning these services even prior to birth. So we have started to institute, I have a visit with patients, with parents that have a diagnosis of critical congenital heart disease during pregnancy to start a conversation of coping and empowering parenting in an ICU setting during a long hospitalization and accessing, social supports and things that can enhance kind of psychological outcomes. Regular screening during the inpatient hospitalizations through postpartum depression screening for parents or neurodevelopmental evaluations during inpatient stays are very important. And then, regular neurodevelopmental follow-up in early childhood and neuropsychological follow-up through adulthood is incredibly important. The Cardiac Neurodevelopmental Outcomes Collaborative has given us some significant time points, but really those transition periods, moving into kindergarten, moving into to second grade when the kind of educational asks are heightened, moving to middle school, high school, and then onward. Those are really critical time points for more thorough evaluations, but integrating screening beyond just those time points is incredibly important to have kind of more a longitudinal relationship with families, but also catch things as early as possible to mitigate as many challenges as we can. So through early intervention and through, just kind of maintaining that relationship across time with families to kind of be used to that conversation about neurodevelopmental risks or mental health challenges that they might face so that they're, open to discussing that and intervening when we need to.
Wonderful. Thank you so much, Lauren.
Sure.
Any questions? Yep. Anita?
I have a question for Dr. Silversides. Could you comment a little bit on how you counsel perhaps a pregnant Fontan who belongs to modified WHO Class 3 versus Class 4, and how you change your strategy in terms of incorporating more specialists or different types of specialists when it comes to organizing multidisciplinary care while taking care of them?
Sure. No, I don't know if I have a completely, well, first of all, I would say that if a Fontan really is not doing well, if you have a failing Fontan, if you have a Fontan where you just can't medically stabilize arrhythmias or those scenarios that I've mentioned, or that's had recurrent heart failure, I would advise those Fontans not to get pregnant in the first place. So I would take at least that approach. Now, remember, just because you advise someone that they shouldn't get pregnant doesn't mean they aren't going to get pregnant. All it means is you're giving them your best advice. I didn't put in a slide, but I usually put in a slide that says all we really are doing is educating women about the risks, and they will decide whether those risks are acceptable or not. So I think even if you tell them they should avoid pregnancy, if they say I'm getting pregnant, you also then have to plan for pregnancy. And to be honest, probably I approach most Fontans similarly. Obviously, I do more surveillance if it was a Fontan in bad shape, but I think all Fontans, I'm looking for the same things, which are the things I've talked about, things where the hemodynamics of pregnancy can destabilize them. Arrhythmias really are the big one. In terms of who I get as part of the team, this is a cardio-obstetric team in general. So if I was at a center where I didn't have ACHD expertise in EP, I would get them involved if there was arrhythmias. If there was some real really big liver issue, I guess I'd get the hepatologist involved. I haven't really seen that. That would be more probably along the lines of a failing Fontan. If a Fontan really had refractory heart failure symptoms, I would probably have the heart function team involved as a back end team. So if they were really failing, I would get the appropriate team. But most of the time, it's me and then the rest of the general cardio obstetrics team. So that includes a high risk MFM. It includes an OB anesthetist who has an understanding of the Fontan circulation. That also means OB anesthetists are different than the cardiac anesthetists that we know. So sometimes, I mean, we're fortunate we have combined OB and cardiac anesthetists that are dually trained, but that would be atypical. So often the OB anesthetist will have to talk to cardiac anesthetists about what do they need to know to tailor anesthesia for a single ventricle patient. You also need you also need to ensure that you have social support. So you may need social work involved or other type of clinical psychologists involved if it's appropriate for the case. And then something that I think we often don't say, but a really important of a cardio obstetrics team is to have your nursing staff have some understanding the cardiac issues for a patient that's delivering, especially some complex patients like Fontan patients where the problems can happen right after delivery while they're in the labor room or while they're being monitored. So that brings me to a last point that, again, I didn't have time to get into, but we would often monitor a Fontan if they have any signs of trouble or if they're not a pristine Fontan, we would monitor them in a cardiac step down or ICU or something after they deliver, just because you can have better cardiac nursing, you can monitor easily better for arrhythmias, you can monitor volume status better. So most of the time you want to place someone after a delivery in that setting. And again, that means you also have to make sure that the team that you're placing them in has some understanding of Fontan physiology and what to look for. I know that's a long-winded answer, but the core of the team is cardiologists with Fontan, pregnancy, ACHD experience, high-risk obstetricians, cardiac anesthetists, and nursing staff that knows what they're looking for.
Excellent. Thank you.
Hey, thanks, everyone. Great talks. This is Arvind Hoskopal, Pittsburgh. I have a question for Sasha regarding exercise trackers and wearable technology. There's obviously a boom. This is nothing new. And I was watching Shark Tank last night. They even have smart pins you can put in exercise machines, and it'll track your exercise. So my question to you is, are those data useful, and do you routinely recommend this in your Fontan or ACHD patients?
I don't normally recommend it just because my sense is that if they're interested in doing that, they'll be doing that, and they're probably good on their own. And if they're not doing it, it's not going to help. Ones with Apple Watches or things that they're already wearing, but sort of it's incidental, and they're not obsessed with it, which is that one subset of psychology, and the other subset is those that are obsessed. But those that are not obsessed, then it can be helpful to look at it and get a sense of what they're actually doing. But I haven't really integrated that. It could be a really good motivational tool if used the right way. I think one of the challenges is there's so many different types and people wear them differently that it's a little bit difficult to know what you're getting, but it could be a really good tool.
Can I just make one quick comment from abroad here? There's a really nice review on biosensors in congenital heart disease in JACC Advances. It's open access, it's free to download. If you want to look there, it's a lovely review article on the topic.
Sasha, I want to ask you two questions. First, I really appreciated the conversation and some of the really nuanced work that you've done in this space, which I think is moving the field forwards in incredible ways. The first is, I agree, and I think most of us in the room agree that the era has sort of shifted from avoiding exercise as a prescriptive restriction to encouraging exercise. And yet still, when we see patients who are getting into their teens and 20s, many of them have now gone through childhood, maybe golfing instead of playing, instead of sitting at home, but not playing soccer or whatever that is. And so I think there's still a lot of work to be done, and I'm curious in your thoughts on how we as a field better get at that with patients and families, really. It's before they get to you and adult congenital and me in the cath lab oftentimes. And I'm curious sort of how we better do that. The second question I have is, these highly nuanced, sort of personalized medicine approaches to taking care of the Fontan are clearly one of the places we need to go. The idea of identifying problems with venous compliance or capacitance being too great and that being a problem, and then focusing on maybe compression stockings and other things like that has real impact for that patient. But it's also hard to bring every patient to a laboratory environment with invasive venous pressures and other things. How do we find the right approach to this? How do we not withhold those nuanced assessments and only use them in very careful, very sort of extreme circumstances? Because I suspect that we are, as you said, we just put them on PD5 because that's what we do. That's probably okay in some patients and not in others. How do we better personalize our approach as we gain more tools and therapies? How do we better sort of understand who needs what?
It's really actually very difficult. I'll do this second question first. I'm now remembering that patient. I had totally forgotten this for the last however many years. So we took her off the sildenafil and off a lot of the diuretics, and she did about the same. She didn't do much better, but she didn't get any worse on much less diuretic. And she came back, I think, 6 months later, and we repeated the same test, except did everything the same, except at that point, we got her up on a treadmill in the cath lab, still awake, still upright, totally different hemodynamic response. And so part of the problem is you can convince yourself that that's exactly what's going on, and then we don't really know all the nuances and know how variable it is because we don't have what's normal. We don't have 150 patients we've done this on and what the various permutations are. So to even get to that, we convince ourselves that we know what we're doing, and probably we're doing a little bit better, but we can also overfit our model to whatever we're seeing. So I don't know the answer to that. It's really hard. The first question, I think we may have a better answer, and that also is going to be exceptionally hard, but I think it's involving patients and parents in trying to work together with us and also with each other to try to figure out how to make that part of the culture, and a collaborative approach across centers and sort of mentorship and making sure that that's an important part. Us sort of communicating, and I'm not a pediatric cardiologist, so I don't have to do this, but like talking to their coaches or the PE teacher to make sure that they understand that to the degree we can tell them it's safe or that they should be treated the same way or whatnot, that I imagine those folks are also having a psychological impact, and that's really difficult. So I don't know the answer to it, but I think working with patients and parents and seeing all the different personalized permutations of that as well, what the obstacles to exercising.
I imagine the FON learning networks like the FON. That's
It's
one of the
well-suited
goals
for
is
that,
to get
very
to,
well suited.
Yeah.
Yeah.
Thanks.
We'll take one last question from the audience.
Hi, I'm Bo Marshall from Ohio State. For Dr. Lorenzi, you mentioned high prevalence of anxiety in patients with congenital heart disease, but we've also learned about and everybody here knows the long-term outcomes and potential limited life expectancy. So my question for you is, in the young Fontan patient or the 20-year-old, 25-year-old doing well, balancing not exacerbating giving them something else to worry about, but also being honest about the potential future trajectory of their lifespan. If you have any practical tips or other advice on that, that's always a hard conversation.
Thank you for the question, and I think that's an incredibly challenging balance. I think kind of starting conversations as soon as possible regarding kind of that transition period and moving into adulthood to kind of normalize some of these conversation topics is incredibly important, because when kind of this new outcomes information does come in this transition to adulthood period, it can be really riveting to our patients. And several of the older Fontan patients that I have that are moving from late teens into early 20s are starting to have some additional stressors in their just general functioning with, ableism in the workforce. I have, one who had hopes to become a police officer or join the military and was unable because of his diagnostic history. So kind of shifting career goals. but I do think they feel the weight of that mortality conversation, and I think, again, kind of evoking, trying to optimize mental health and using kind of preventative medicine ahead of time so that they're in the best kind of place to receive the growing information as they traverse kind of their medical trajectory is important. Kind of pulling together social supports even as they move into adulthood, and starting the conversations as early as possible. I think also, the kind of way in which we formulate these discussions is really powerful, not like, if you're experiencing this, but how you're experiencing it, because it will come and it will be stressful and these challenges likely will present. So kind of formulating the conversation more of how you're managing it rather than if it's present, I think is important. But, having that kind of presence of mental health within the cardiac home, I think can help with that, so that the novelty of those harder conversations that may come with the medical complications moving into adulthood or mortality discussion aren't new, but when they come, they're well supported. I don't know.
Fantastic. Thank you very much. With this, we're going to go ahead and close this session. Thank you very much for our fantastic speakers and moderators. And we will start right at 10. So we have a short break till 10 o'clock. Thank you.